So there's four main potential pigments in the skin. The big one I want you to know is the melanin. That's the brownish pigment in our skin. We also have products that provide blue, red, and yellow pigment, but they're not predominant. How much of this pigment each person has in their skin determines their skin phototype, and anywhere in the Fitzpatrick scale. If a person has increased melanin in the epidermis, it's called hypermelanosis. The opposite, if they have less melanin in their skin, is hypomelanosis. It can be caused by two different ways. It can either be an increased number of melanocytes that are producing more melanin, and that's an example of that is a lentigo, a sunspot, and that is called melanocytic hypermelanosis. If your number of melanocytes are the same, but the existing melanocytes are just producing more melanin, and that is called melanotic hypermelanosis. And an example is melasma. So with melasma, there's not an increased number of melanocytes. The existing melanocytes are just producing more pigment. Hypomelanosis, again, it can be just a decreased production of melanin only, which is like an albino. That's called melanopenic hypomelanosis. That kind of goes along. Melanocytopenic hypomelanosis, a lower number of melanocytes, is an example is vitiligo, which we're going to talk about. And that's where you have a lower number of melanocytes producing less melanin. So conditions like this, not a serious thing as far as life-threatening or anything, but it can sure have a profound impact on a person's life, especially if they're, so conscientious about everything like a teenager is. So vitiligo is your most common pigment disorder. This is an acquired hypopigmentation, and this you lose melanocytes. You're going to see this. It's fairly common. 10 years to 30 years of age is when you're going to mainly see it, and it's not discriminatory for males or females. Now, it's felt that this is genetic. There's a genetic component for sure, but they also feel like it's autoimmune, because it's oftentimes associated with other autoimmune disorders, such as thyroiditis or thyroid disease, diabetes, alopecia areata. So it's felt that a person, for some reason, develops an antibody against its own melanocytes. We basically talked about all that there. So typically what happens is they get these depigmented, complete loss of color that just slowly expand outward. And kind of a difference, we're going to talk about post-inflammatory hypopigmentation. I mean, you still have pigment in there. It's just lighter than the normal. This is complete loss. There's different patterns. Generalized, segmental, where it's just on one half of part of the body. Acrofacial is probably the most common on the feet and hands and face, or a combination of these. So these patches are not going to have redness or scaling. They will become more accentuated with a black light or a woods lamp. And it likes, well, I'll show you pictures of where it likes. Even the hair and mucosal membrane can be involved. when you have a circumscribed, I need a drink on that one. Unfortunately, it doesn't have bourbon in there, but circumscribed area of white hair, which would be equivalent to a patch of white skin, is poliosis or leukotrichia. Trichia, it means hair, so leuko, white hair. And we've talked about Kebner's phenomenon, where certain rashes or conditions tend to occur in areas of skin trauma. Vitiligo is one of them. Psoriasis does that. So this is the areas it likes. It loves the feet and hands. It likes circumferential around things. It loves around the mouth, the lips, around the eyes. It likes the hands and feet. It likes the groin area, and then the knees and elbows and armpits. This is an example of segmental. See how it's just on half of the face, doesn't cross the midline? And that's stark. That's stark whiteness. There it's in the armpit. There it's on the penis. Circumscribed. On the back of the hand. And that's how it's going to light up, really become apparent with the woods lamp, a black light. There is an example of the poliosis. Have you seen, there's a guy who used to have his own little soup, or what was the name of that? Not soup. And then he did the Wipeout show, you know, that where they're on water, or they have, you guys know what I'm talking about?
Yeah.
Okay, well he had some of this. He had a patch over here on the side of his head of this poliosis. You don't usually have to biopsy this. You should be able to tell. Anytime you have somebody, you might consider, do I check labs on every single person? No. But I think, especially if they're older, an adult versus a little kiddo, you might consider doing some screening for thyroid with a T4 TSH, screening for lupus or other cutaneous, or excuse me, connective tissue diseases, and just a CBC. If they have symptoms that are suggestive of thyroid disease, you might even think about checking your thyroid antibody panel, see if they have antibodies against their thyroid. If you happen to get a biopsy, it's just going to give a report that the epidermis doesn't have melanocytes. This is very chronic and very hard to treat. I think it's very important. I mean, if a person just has a couple of, spots, you should be able to tackle that. But if it's real generalized, it's just tough. And I think you need to be very realistic with your patient about that, and talk to him or her and say, this is going to be tough. This is going to be you got a long haul ahead of you. And kind of sad thing is that even if you find that the person has thyroid disease, by treating that thyroid, it doesn't necessarily help the skin to clear up at all, unfortunately. Very important to talk to the patient about sunscreen for two reasons. One, that skin that is devoid of melanin or melanocytes producing melanin, incredibly at risk for getting severe burns and skin cancer down the road. The melanin in our skin helps absorb some of that sunlight, and it's a protective. I don't have much of it, except in freckle form, but it is protective. So if you don't have that around, you can get some bad burns in there. But the other reason too is to make it less noticeable. If you're out in the sun a lot, the other normal skin is going to naturally become darker. And so it will become more apparent that way. You know, in my skin type, you're really not gonna notice vitiligo too much with me. But you get a darker skinned individual and it's very apparent. They have some good makeup. I'm drawing a blank on the name of it right now. I know they have it at Sephora and what's that other place? Which one? Ulta, yes. Dermablend is the name of it. It really does an amazing job, and I would recommend that you suggest this to your patients.
It covers tattoos too.
Oh, is that right?
Performers use it a lot.
No kidding.
On stage.
Well,
Fun fact for you.
never knew that. Yeah, a lot of those people that come in saying, oh, I did this when I was drunk and oh, let's just, how do I now get rid of it? Okay, repigmentation. How do we stimulate those to get pigment back in that skin? So our goal is to try to preserve some melanocytes that are not fully destroyed, and we can kind of recruit some from surrounding tissue or the hair follicles. The hair follicles may, unless if they're white and devoid of pigment, but those that aren't, we can sometimes recruit some pigment cells from there. So how do we do that? Your steroid creams are probably the number one for localized disease. You're going to use more potent, unless if it's on the face or the groin or something like that where the skin is thinner, then you're going to use more middle of the road. You always need to monitor for skin atrophy or steroid atrophy. It's going to look thinner, look more like transparent almost, look like onion skin, and may have telangiectasia. You can also use the calcineurin inhibitors, your pimecrolimus and tacrolimus, or your Elidil and Protopic. I will use that a lot on the face, especially around the eyes where you really don't want to use a steroid. Or I will use it kind of in conjunction. Once we're starting to get pigment or we have repigmented, then use that for maintenance. You can also use light therapy or laser therapy. Generalized vitiligo, when you have it widespread, I mean, they would have to be bathing in topical steroid cream, so that's just not practical. So your first line therapy is going to be your narrowband UVB phototherapy. And with that, they generally have to go in 2 to 3 times a week. And based on their Fitzpatrick skin type, they start at a specific joule of ultraviolet light, and every so often they gradually go up to the point to where just starting to burn, and then they come down off of that. You don't need to know that, I'm just telling you. Or oral PUVA, where you use ultraviolet UVA with an oral medication that sensitizes your skin to that ultraviolet light. When you see repigmentation, you're going to typically see it around that hair follicle. So it's going to look kind of spotty, and then it will fill in. Again, you're recruiting the pigment cells from those hairs, the hair follicles, so that's where you're going to see the pigment more. There's some on the face after treating with Protopic for 3 months. There is a depigmentation to where you lighten the normal skin, and this is going to be used, I mean, Michael Jackson, do we ever know if that was for real or was that something people just made up? But I've never done this. This is gonna be more in your dark skinned individuals and more severe cases. But this is a bleaching agent, and it is permanent and irreversible. So you need to make sure they know what they're getting into. And I imagine there's only certain places, maybe plastic surgery, or I don't know who would do this. We didn't do that. But good success rate. And here are some examples of that. Okay, melasma. Again, this is an acquired disorder. You're not born with it. You acquired it as you get older. Of hyperpigmentation. Hyperpigmented macules, mainly on the face, but sometimes the upper body, also known as chloasma or the mask of pregnancy. Primarily, you see this a lot during pregnancy because it is strong. They think there's a genetic component and a hormone component and a sun component. We don't know exactly what causes it, but we do know that those three things are important, are involved. You tend to see it more by far more women, 90% women, in their reproductive years in darker skinned individuals. But you see it in lighter skin too. So family history of it. If a person lives in Oklahoma where there's intense sun, if they're pregnant or on birth control pills, anything where that estrogen level is higher. Okay, we talked about that. We know that UV radiation stimulates those melanocytes. That's why we treat vitiligo with it. Again, they have three major patterns. Your centrofacial, your forehead, nose, chin, upper lip, and then they've got a couple others. And this is what that looks. It's just patchy spot, just, you can't miss that. You do just the opposite. You use hypopigmenting. You want to lighten it, lightening agents. Most common are hydroquinone and azelaic acid. Hydroquinone is over the counter in a 2% cream. Porcelana, they've got, I'm sure at Ulta, they've got 15 different things you can purchase. Azelaic acid, and then prescription strength is 4% cream, or you can compound it up to 10%. The higher you go, though, the more potential irritation, skin irritation. Yeah.
In your experience, was this pretty successful?
Uh-huh. Yeah, but they have to stay out of the sun and they have to use sunscreen, which most of them don't want to do. Okay, and you have to use it for pretty long. Azelaic acid is something that you can use. They're both pretty effective, but you have to use it for a pretty long time. One thing I do want to mention with hydroquinone is you can sometimes have, for prolonged use, you can have risk for ochronosis. I have to think about ochronosis. And that is kind of it looks like pepper, a darkening of the pigment, darker pigment. So you don't want that if you're trying to get rid of melasma. Your person is not having. So what it's kind of debatable how long you can actually use these. In the paper I read, a year is probably safe, but I'm not going to push it that far. What we would always say is don't use it for longer than 3 months. Take maybe a month off and then start it back up again. Sometimes we'll use combined products. There is something called TriLuma, which has hydroquinone, retinoid, which gets that cell turnover going faster, and a mild steroid to kind of offset the irritation that the other two can cause. That can work really, really well too. Yeah.
Could you just use the retinoid on its own instead of the lightening?
You can. Good. To start with, it won't be as effective, but yeah, you certainly could. You sometimes will compound a product with all of those plus or minus ascorbic acid, that vitamin C ascorbic acid, again, just to get more peeling. But the biggest potential side effect is irritation. Wow, gracious, got a movie going. You can see pretty quick improvement, up to a month, or within a month maybe, but it's gonna take about 6 months of treatment to see your maximum improvement. Chemical peels, maybe, maybe not, in conjunction with the hydroquinone and azelaic acid. Have to tell them to wear sunscreen. Sunscreen, sunscreen, sunscreen. While they are getting treated and afterwards, because it's going to come right back if you don't. You want to use broad spectrum with a barrier product in there as well. And if you can, stop the birth control pills or whatever. Post-inflammatory hyperpigmentation. You've heard me talk about this. This is a increase in the melanin after there's been some trauma or inflammation to the skin. Very, 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 very common, especially in your darker skinned individuals. So these inflammatory mediators cause this pigment production, and then that excess pigment just kind of leaks down into the dermis, and so it's real resistant. Since it's deep, some of it is deep, it's hard to treat. You just kind of have to let it do its own thing. Can you use some of the treatments like you use for melasma? Yes, you can, but I usually say I'm not going to make any promises that this is going to help any more than time alone will. And again, sunscreen, having them stay out of the sunlight, because you know, you got a tan and you stay out in the sun, it's going to keep a tan. Same sort of thing. The more sun exposure that dark pigment has, it's going to stay darker longer. Whoa, excuse me. So this hyperpigmented macules, kind of ill-defined at the site of a prior inflammation or injury. The best thing you can do is to stop that inflammatory process, whether it's eczema or acne or whatever. You got to get that under control before we can expect that pigment change to get better. Depigmenting agents can be used, but again, I'm not real convinced it does much. And it's going to be slow. I usually say this will resolve on its own, but it's going to be several months from now. And avoid the sun. And that is examples of post-inflammatory hyperpigmentation. Acne, and that's what oftentimes will get people into your office, because they're like, look at my acne. And really the only way you can tell, if you would be rotating with me, I'd say get your finger up there and feel that skin. Is that all flat and it's just hyperpigmented macules? Then that's it, your acne's clear, it's just that pigmentation that needs to go back to normal. Now, if she's got a couple of active papules, you know, inflammatory papules there, you can tell. So we would have to get her acne under control for sure. He probably had either psoriasis or eczema, I'm guessing, or something, and that looks like the rash itself is clearing, but he has patches of post-inflammatory. Here's more in a Caucasian. And again, it's anywhere from a light pink to a darker pink, purpley color. And then probably acne on the back. And then post-inflammatory hypopigmentation, where you have decreased loss of melanocytes. In some people, they just tend to lose pigment cells rather than produce more pigment. This one is more common in your lighter skinned individuals. You can tell where I have self-induced or permanent hypopigmentation, where I have frozen a few things off of my skin. Well, I peeled, or I stripped all that pigment from my freckles. I need to do that all over. So it leaves that permanent hypopigmentation sometimes. sometimes you can have both, in various, don't be surprised with that. I'm trying to forget, okay, hypopigmented to depigmented macules found at the site of inflammation or injury. I would say hypopigmented, scratch the depigmented, okay? Vitiligo is complete depigmentation. So for testing purposes, vitiligo is complete depigmentation. Hypopigmentation is going to be your post-inflammatory. And your vitiligo tends to progress. Okay, if you have your site of injury or inflammation is going to be where your hypopigmentation is. It's not going to continue to get bigger. Again, you got to calm the inflammation down before you can expect changes, and therapy is prolonged. So repigmentation, here you want to get them out in the sun a little bit. Not to where you're burning, but that sun is going to stimulate that melanocyte. And there's some examples of hypopigmentation. You see that a lot with eczema. People will have had a patch of eczema in their antecubital area, and it just is kind of light like that, and that takes longer for that to resolve. And we're done. Woohoo! Questions? Questions about the pharmacy